Now we'll start with the sympathetic nervous system. Again, in the sympathetic nervous system, we have two types of drugs. They are known as sympathomimetics and sympatholytics. I told you same schema. Sympatholytics. Sympathomimetics are also known as adrenergic drugs. Parasympathomimetics are known as cholinergic drugs. Why are they known as adrenergic drugs? Because major neurotransmitter is norepinephrine, that is also known as noradrenaline. That is why these are known as adrenergic drugs or anti-adrenergic drugs. That's all. These are the two classes of drugs we are going to study. Now, how did we start the PNS chapter? By studying about the neurotransmitter. The same thing we are going to do here. So, what is the neurotransmitter here? It is norepinephrine. So, it starts with tyrosine. Tyrosine is converted to dopa. Dopa is converted to dopamine. Now this dopamine is going into the vesicle, and inside the vesicle dopa is converted to norepinephrine. When the calcium comes in, this dopamine or norepinephrine will be released according to the situation. That is what I am saying. This is why I didn't tell you about sympathetic nervous system before. See, in sympathetic nervous system, if you see here, let us suppose this is an organ, that is heart. This is an organ, that is heart. The neurotransmitter is norepinephrine and the receptors are either alpha or beta. On the heart you usually have beta receptors. Okay, this much you already know. But what I am saying is, in some areas dopamine can also be released. Example, it can be released in kidneys, it can be released in a brain. Okay, so in kidneys and brain dopamine can be released. And there is one more exception. The exception is sweat gland. On the sweat gland, even though it is part of sympathetic nervous system, sweat gland has a receptor that is known as M3. Now I told you, where are the receptors, muscarinic or nicotinic? The neurotransmitter is supposed to be acetylcholine. So that is the reason why, if you remember, in the organophosphate poisoning, I told increased acetylcholine will cause sweating. Why? Because it acts on the M3 receptor on the sweat gland and it will cause sweating, even though it is part of sympathetic nervous system. This is what I want you to understand. These are the exceptions. Exceptions are usually tested in the exams. So common is norepinephrine, but the other ones are dopamine and what? Acetylcholine in sweat glands. That's all. Now, also, if norepinephrine acts on the adrenal gland, it will release epinephrine. This epinephrine is going into the blood and it is going into all the organs. If a substance is released into the blood going into the distant regions, this is also known as hormone. So norepinephrine is a neurotransmitter, epinephrine is a hormone here, and the minor neurotransmitters are dopamine and acetylcholine. This is what I want you to remember. Now what I am saying is, tyrosine is converted to dopa, dopa is converted to dopamine, dopamine to norepinephrine, and norepinephrine is released. If it is in the brain, dopamine can also be released. Now this dopamine and norepinephrine will act on receptors that are known as alpha, beta. Now you can see here both of them are GPCRs. So alpha and beta are G protein coupled receptor. That's all. So if you understood this much, now what will happen to dopamine and norepinephrine? They will be taken back inside, and then they are metabolized by MAO and COMT. MAO and COMT. This is what is happening in the body. So either dopa or norepinephrine is released. When they are released, they are taken back, reuptake of norepinephrine and dopamine, and these are metabolized by MAO, monoamine oxidase, or COMT, catechol O methyl transferase. These are the enzymes, they will metabolize them. Did you understand this much? Yes. Why? Because all of these are monoamines. Dopamine is a monoamine, norepinephrine is a monoamine. Yes. Now, epinephrine, norepinephrine, dopamine together are known as catecholamines. That is why we say it catechol O methyl transferase. Yes. That's all. Now, if you understood the neurotransmitter, how it is produced, now we will see the receptors. What are the receptors? I told you we have alpha and beta receptors. So, in alpha, there are two types, alpha 1, alpha 2, beta 3 types, beta 1, beta 2, beta 3. How to remember it? Again, I will tell you the same trick. It will be easy for you to remember. See, alpha. Alpha means the most important person. No? So alpha receptor is supposed to be the most important receptor, alpha 1. So alpha 1 is the most important receptor. That means it should be present almost everywhere in the body. Yes, it is. I'll tell you how. So what is the most important sense in our body? I figure it is vision. So on the eyes, alpha 1 is present. Okay. And it is also present in the prostatic urethra. And is also present in prostatic urethra. Now, all over the body we have blood vessels. So it is present in the blood vessels also. It is present in the blood vessels also. Now, in the eyes, what is it doing? In the eyes, what is it doing? Sympathetic nervous system, so it should cause mydriasis. If it has to cause mydriasis, there should be contraction of radial muscles of iris. So it is causing smooth muscle contraction. Now you should be able to tell me, it is GS, GQ or GI? Yes, it is GQ. So in the prostatic urethra, what will it do? It will again cause smooth muscle contraction. Yes or no? So it will cause smooth muscle contraction. That means urethra is contracted, urethra is closed. Now will there be urination? No. So that is why there is decrease in urination. That is happening because of alpha 1. Now what will happen to the blood vessel? Blood vessels also have smooth muscles. So there is vasoconstriction. This is what is very important. You have to remember alpha 1 receptor. Even if you remember the other receptors or not, alpha 1 is really important. If you forget all the other things, I want you to remember alpha and beta receptors. Okay. Next, alpha 2. See, almost all the receptors that I told you are present in the postsynaptic region. You can see this is synapse. After the synapse, you have alpha and beta receptors. But alpha 2 is a receptor that is present on the presynaptic membrane. Why is it present in the presynaptic membrane? Let us suppose if norepinephrine is released in a higher quantity, what will happen? Yes, they will act on alpha receptors, beta receptors on the postsynapse, but the excess quantity will go into the presynaptic membrane and it will activate this alpha 2. What will this alpha 2 do? It will decrease the release of norepinephrine. It will do what? Decrease the release of norepinephrine. That means it is breaking the release, stopping the release. That is why we call alpha 2 as a brake. Because alpha 2 will decrease the release of neurotransmitter. That's all. So alpha 1, eyes, prostatic urethra, blood vessels, alpha 2 is a brake. That's all. Now coming to the beta receptors. How do you remember this? I told you muscarinic receptors are mature receptors. So it listens to the brain and fills up its stomach. Now beta, how do you write beta? BETA. BETA means beta, no? Beta means small children, no? So small children are immature, don't you think? So what will immature people do? I told you in the previous story, immature people will first listen to their heart. So beta 1 is present in the heart. That is how you can simply remember the muscarinic and beta receptors with help of one story. So in the heart, it activates SA node, increases heart rate. Activates AV node, increases what? Conduction. Acts on myocardium, increases contraction. You can see it is causing stimulation of cardiac muscle and the AV node, SA node. So it is GS, it is stimulatory. GS, that's all. Now beta 3 is the last receptor, so it is present in the last organ, it is in the bladder. This is what is very important. Please concentrate on the bladder. MCQ. Okay. On the bladder, what is beta 3 doing? What is it doing? Try to think. Sympathetic nervous system. That means it will block urination, it will cause relaxation. So it will cause relaxation of smooth muscles of bladder. This much you already know. Then it should be GS. But this is not what is important. What is important here, it is used in overactive bladder. It is used in overactive bladder. If you remember the overactive bladder, we have studied of the stimulated bladder. So in the overactive bladder, you can also use beta 3 agonist. Yes, because it is causing relaxation of smooth muscle. What are beta 3 agonists? They are, please remember, mirabegron and vibegon. Now, why is this so important? I will tell you. Mirabegron and vibegon are actually the drug of choice in overactive bladder. It is drug of choice in overactive bladder. So if I ask you, a person is having overactive bladder with dementia, which drug will you give? Trospium, solifenacin or mirabegron? Obviously, the answer is mirabegron. Why? Mirabegron is the drug of choice anywhere for overactive bladder. Did you understand? So the drug of choice for overactive bladder with dementia is mirabegron. Why begron? Because beta 3 receptors are not present in the brain. Muscarinic receptors are present. So how can the question be asked? Overactive bladder with dementia, drug of choice mirabegron or vibegron. Now, if they ask you anti-muscarinic drug, you will write trospium. If trospium is not in the options, you will write soli or darifenacin. So these are the MCQs that can be framed in the upcoming exams. Please concentrate on this. That's all. That is about the beta 3 receptor. Now coming to the beta 2 receptor. Beta 2 receptor is present everywhere else in the body. Where else? First we will see skeletal muscles. Yes, it is also present on cardiac muscles. Yes, it is also present on smooth muscle. If it activates the skeletal muscle, it will cause contraction. Activates the cardiac muscle, contraction. If it contracts too much, it might cause tremors. It might cause palpitations. Increased contraction of heart will cause palpitations, isn't it? Now, smooth muscles, where are they present? They are present in the bronchus. So it will cause bronchodilation. They are also present on the uterus. So it will cause uterine dilation. Why? Think about it. Contraction here, you already know. Why? Because it is GS. I already told you bronchus and uterus. In bronchus, in sympathetic nervous system, there is bronchodilation. Bronchodilation means smooth muscle relaxation. Smooth muscle relaxation should be GS. So GS will activate the other muscles. That is why we have skeletal muscle contraction, cardiac muscle contraction. Did you understand this much? Yes. Now, what is most important? Whenever a person is having hypoglycemia, it is an emergency. Emergency will activate the sympathetic nervous system, especially the beta 2 receptor. When beta 2 receptor is activated in the liver, it will increase the glucose. And in the pancreas, it will act on the beta islet cell and it will increase the insulin release also. You might ask me, if glucose is increased, insulin is really increased, insulin is supposed to decrease glucose. No. See, what I am telling you is, there is lot of increase of glucose. There is some increase of insulin. Now, this increase in glucose is much more in comparison with the insulin. That is why still you will have increase in glucose levels. Okay, good. So, insulin will also reduce the potassium levels if insulin is increased. Why am I telling you this? From this you will get 1 or 2 MCQs. I will tell you while we are discussing the MCQs. So, this is what I want you to understand. Alpha is present in the eyes, prostatic ureter, blood vessels. Alpha 2 is a brake. Beta 1 is present on the heart. Beta 3 is in the bladder. Beta 2 is present rest of the body. Yes, good. Now coming to the sympathomimetic drugs. I told you, everywhere it is going to be the same. So we have 2 classes of drugs. What are they? Direct acting, indirect acting. How does direct acting work? They act directly on receptor. Indirect, they will increase the neurotransmitter. So direct acting, indirect acting, and in this we have mixed acting. What is mixed acting? It is nothing but it has both the effects. That's all. It acts directly on the receptor and it also increases the neurotransmitter. Nothing new. Okay. Direct acting, indirect acting. We will see all these drugs. So, first coming to the direct acting drugs. Indirect acting drugs. See, in the body we have neurotransmitters and hormones like norepinephrine, epinephrine, dopamine. That is what is activating the sympathetic nervous system. So what did we think? Why don't we make the same things that are present inside the body? They will act on the sympathetic nervous system. True, that is what the scientists have done. Now, these are also known as endogenous catecholamines. Why? Epinephrine, norepinephrine, dopamine are catecholamines. They are present inside the body, so they are known as endogenous catecholamines. This is what I want you to remember. Epinephrine and norepinephrine will almost act on all the receptors, alpha 1, alpha 2, beta 1, beta 2, beta 3. Yes, only exception is norepinephrine will not act on beta 2. This is what I want you to remember. When it is not acting on beta 2. See, beta 2 is a GS receptor, so it will cause relaxation of smooth muscle. So, smooth muscle is also present on blood vessel. Do you accept? It will cause vasodilation. This is one very important concept. That is why I told you in the end. So alpha 1 is causing vasoconstriction, beta 2 is causing vasodilation. How can you remember this? You can write it as A, B, C, D. A first alphabet, B second alphabet, alpha 1 vasoconstriction, beta 2 vasodilation. At least this much you should know. Now, see here, epinephrine is a potent cardiac stimulator. That means it works mainly on the heart. So it is drug of choice in cardiac arrest. It is drug of choice in cardiac arrest. Since it is a potent cardiac stimulator, it is drug of choice in cardiac arrest. Okay. Now coming to the norepinephrine, it is a potent vasoconstrictor. That means it will constrict the blood vessels very well. If there is vasoconstriction, it will increase the BP. So this will increase the BP. It can be used wherever BP is less, especially in the shocks. Now it is drug of choice in vasodilatory shock. That's all. Why? Because there is vasodilation. Because of vasodilation, there is drop in blood pressure. That is what is vasodilatory shock. So norepinephrine is the drug of choice in vasodilatory shocks. Yes, you must have heard neurogenic shock, all these shocks. Now, there is something known as anaphylactic shock. This is also a vasodilatory shock, but in anaphylactic shock, the drug of choice is epinephrine. Why is that? That is the most important thing that you need to understand. Because in anaphylactic shock, there is bronchoconstriction. Now you can cause bronchodilation only with beta 2. Only epinephrine is acting on beta 2, that is why we give epinephrine here. The doses are what is important. In cardiac arrest, we will give 1:10,000 IV, and in anaphylactic shock, we give 1:1000 IM. Most commonly asked in the exam. This is what is very, very important for the exam. Okay. Now, if you understood this much, dopamine. Dopamine has a dose dependent action. It works on different receptors based on the dose. So, how can you remember this? It acts on 3 receptors. Dopa, you can write it like this. DOPA, dopa. Yes. So, in the low dose, it acts on D1 receptor. Yes. Now, it is dopa. Next. P, you can write it like this. It looks like beta. O means 1. So D1, beta 1 and A1, that is alpha 1. So in the lower dose, it acts on D1. In the medium dose, it acts on beta 1. In the high dose, it acts on alpha 1. This is how you can remember the receptor functions of dopamine. It is usually given in the microgram per kilogram per minute. But these doses are not important at your level. Now, this can be used in a patient who is having shock with oliguria. Why? D1 receptor is present on the kidney, and D1, D for D, it will cause diuresis. Diuresis means increased urine output. So it can be used in oliguria, shock with oliguria, dopamine. That's all. Norepinephrine, potent vasoconstrictor, so vasodilatory shock, except for anaphylactic shock where we use epinephrine, cardiac arrest, epinephrine. That's all you have to remember in this. Now, then what did we do? We try to make the catecholamines that are not present inside the body. They are known as exogenous catecholamines. Exogenous catecholamines. There are many names: isoprenaline, phenaldopamine, dopexamine. All of these you don't have to remember. One thing I wanted to remember is dobutamine. Dobutamine works especially on the beta 1, and this is drug of choice in acute congestive heart failure. Dobutamine is drug of choice in acute congestive heart failure. That's all. Now, if you understood this much, so usually in the exam they'll ask something about epinephrine. When you give epinephrine, when you first give epinephrine, it is in higher quantities in the blood. When it is in higher quantities, it will act on alpha 1. When the quantity decreases, it will act on beta 2. This is what I want you to remember. So what will happen? When you first give, it will act on alpha 1, it will cause vasoconstriction and it will increase the blood pressure. Okay. When the dose decreases, it will cause vasodilation and it will decrease the blood pressure. So this is what is happening normally. This is the phenomenon or biphasic pattern of BP that is given by Dale. Okay. Now what Dale is saying is, if you give epinephrine along with alpha blocker, that means it will block the alpha receptor. will you get this increase in BP? No. You will only get the decrease in BP. That is what is known as vasomotor reversal of day. It is seen in the graph very easily. The graph has reversed. That is what is known as vasomotor reversal of day. That's all. Easy to understand. This is the question that has been asked so many times in the FMGE exam. Vasomotor reversal of day. When you give alpha blocker along with the epinephrine, this is what can happen. The BP can decrease. Please try to understand this much. Next, we have finished with the catecholamines. Now, the other one is non-catecholamines. That means they don't look like catecholamines at all. Endogenous catecholamines, exact catecholamines. Exogenous means these look like catecholamines but they are not in the body. Now, the next classification is non-catecholamines. Now, what can be the drugs? You have 3 receptors. No, what are they? Alpha 1, alpha 2, beta 1, beta 2, beta 3. So we can have these many classes of drug. Alpha 1 agonist, alpha 2 agonist, beta 2 agonist, beta 3 agonist. But beta 1 agonist, we already have one drug that we have studied in exogenous catecholamines. Do you remember? Dobutamine. So we did not make anything else. But there is alpha 1 plus 2 here. So these are all the non-catecholamines that are present. Now we will see the most important ones for the exam. Now, how to remember these names? Alpha 1. Alpha 1 means it is causing what? Vasoconstriction. So it can be used wherever the patient is having vasodilation. Okay, good. Use wherever patient has increased vasodilation. Okay, because it is causing vasoconstriction. Good. Alpha 1 agonist. How to remember? I told you. Alpha means most important person. Alpha 1, alpha 2. Now you tell me, who is the most important person in the country? Obviously, it is PM. So alpha 1 are PM drugs. Alpha 2 means second most important. Now, after country comes the state. So, state is CM. So, alpha 1 is PM drugs, alpha 2 is CM drugs. Done. So, alpha 1 is phenylephrine, midodrine. You can use it wherever you require vasoconstriction. Where do you require vasoconstriction? There is a problem called priapism. Priapism means uncontrolled erection. Why does erection happen? Because of vasodilation. So if you cause vasoconstriction, will you treat this? Yes. Now, midodrine is drug of choice in postural hypotension. Why? Why does hypotension happen? Because of vasodilation. So if you cause vasoconstriction, will you treat this? Yes. Next, coming to the alpha 2 agonist. I told you, remember 2 drugs, CM drugs. What are they? Clonidine and alpha methyl dopa. Clonidine and alpha methyl dopa. Now, the most important thing that I want you to understand is, all of these drugs are sympathomimetic drugs. But alpha 2 is a brake. So, if you give alpha 2 agonist, norepinephrine will decrease. If norepinephrine is decreasing, these sympathetic functions are decreased. So, alpha 2 agonist, even though I am saying it, in the sympathomimetic drugs, these are sympatholytic drugs. Why did I keep it in this chapter then? To maintain the continuity of this non-catecholamines, I have placed it here, but these are sympatholytic drugs because it is decreasing the neurotransmitter. Please get this into your head. Did you understand? Clonidine and methyl dopa. So if it is sympatholytic drug, yes, will it increase the BP or decrease the BP? Obviously, it will decrease the BP. That is why we use it in hypertension, especially a patient who is having chronic hypertension in pregnancy. In gynecology, you study what is chronic hypertension in pregnancy and pregnancy-induced hypertension. In chronic hypertension in pregnancy, you will use something known as methyl dopa. Yes, you will use something known as methyl dopa. Next, coming to clonidine, there are a lot of uses of clonidine. It can be used for hypertension, true. It can be used for lowering the withdrawal symptoms of opioids, true. And the most important function I will tell you in some time. Okay. Now, in the NEET-PG, there has been one question that is about tizanidine. Tizanidine is a muscle relaxant. NEET-PG में पूछा था. Yes. For FMG, please remember clonidine and alpha methyl dopa. It is done. Alpha 1 PM drugs, alpha 2 CM drugs. Now, alpha 1 plus 2 agonists, they are xylometazoline and oxymetazoline. These can be used in allergic rhinitis. Why in allergic rhinitis? There is vasodilation of nasal vessels, so you can use it in allergic rhinitis. That is what you see in Otrivin drops. These are those. Next, most important is beta agonist. Now, beta I told you there is no beta 1. Next is beta 2. Beta 2, where are they present? It is present everywhere else in the body. Aren't they present on the bronchus? Yes, if it is present on the bronchus, it will cause vasodilation. So, it can be used in bronchial asthma. Do you remember Sama, Aima, Lama? Same here. Saba, Laba and Vilaba. What is important to us? Saba is terbutaline salbutamol, Laba is formoterol. Please remember this much, that's enough. It is used in bronchial asthma. Now, Ritodrin. Ritodrin can be used for uterine relaxation. It is used, it will cause uterine relaxation. That's all about beta 2 agonist. Good. Beta 3, told you so many times, mirabegron, bibegron. It is drug of choice in overactive bladder. What is drug of choice in overactive bladder? With dementia, mirabegron. Anti-muscarinic drug, trospium. If trospium is not there, next, sulfenacin, darifenacin. This is what I want you to remember. This concept is really important. How can you remember the drug names? I told you overactive bladder means there is increased activity of the bladder. That means excess activity of the bladder. So you can remember it like this, mirabegron. Yes or no? So what I'll try to remember is, mira means mera, B means bladder, E means excess activity. Mera bladder excess activity gone. That is mirabegron. V means we, all of us. Vibegron, our bladder excess activity gone. So mirabegron, vibegron are the drug of choice in overactive bladder. This is how I remember these drugs. Okay, good. Next, that's all about the direct acting drugs. Next, coming to the indirect acting drugs. Indirect acting drugs means it should increase the neurotransmitter. That means, let us suppose if norepinephrine is present in the vesicle, if it pushes the norepinephrine outside, that is what is known as norepinephrine displacer. Examples are tyramine and amphetamines. Now, this norepinephrine is being reuptaken, so you can block this. These are uptake inhibitors, and after this they are metabolized by MAO and COMT. You can block these. These are MAO and COMT inhibitors. So these are the 4 classes of drugs. That's all. So norepinephrine displacer, uptake inhibitors, MAO inhibitors, COMT inhibitors. In all of these, what are important? Amphetamine. Amphetamine like drug is methylphenidate. Methylphenidate is the drug of choice in ADHD. Now, in these drugs, what are the important points you have to remember? I have given it in the table. We'll try to see this. What is the drug of choice in priapism? It is phenylephrine. I have already told you. Now, in chronic hypertension in pregnancy, which drug would you use? It is methyl-dopa. ADHD, I told you, what is the drug of choice? It is methylphenidate. Please remember this. Methylphenidate. Now, if you give a methylphenidate in a patient with ADHD, if the patient has tics, it will worsen the tics. So, in this patient, you will give clonidine. Very important topic in psychiatry. ADHD, methylphenidate, ADHD with tics, clonidine. And in psychiatry, there is one more drug, ADHD with family history of addiction. There you give atomoxetine. Okay. Now, postural hypotension, you give midodrine. This all you know. Only thing I have added is methylphenidate. And what is the drug of choice for narcolepsy? It is modafinil. So this is what I want you to remember for indirect acting drugs. And mixed acting drugs, we don't use it nowadays anymore. These are ephedrine, pseudoephedrine, norepinephrine. Yes, they are not used anymore. So again, for clinical importance, direct acting, indirect acting. Direct acting only we have studied, mostly concentrate on the catecholamines. Then they might ask you the vasomotor reversal of Dale. Yes, after all of this, then you have to study about the beta 2 agonist. Now, most important and commonly asked question are, what are the side effects of beta 2 agonist? What are the side effects? Whenever beta 2 receptors are activated, I already told you, in the skeletal muscles, it will cause tremors. In the cardiac muscles, it will cause palpitations. In the liver, it will increase glucose, hyperglycemia. If it is increasing insulin, it will decrease potassium. Most important question. They will give these 4 options and change one of the things. They might even give you hypoglycemia or hyperkalemia. That is the wrong option. They'll ask you which is not the side effect of beta 2 agonist. So if you understood this much, this is more than enough when it comes to sympathomimetics. Okay, so have you revised the sympathomimetics? We have talked about the catecholamines and non-catecholamines, and then we have seen the indirect acting drugs like uptake inhibitors, norepinephrine releasers like tyramine and amphetamines. Yes, now we will start with the sympatholytics. They are also known as anti-adrenergic drugs. I told you the same concept here also. So there are going to be 2 classes of drugs. What are these classes of drugs? Direct acting drugs and indirect acting drugs. Direct and indirect acting drugs. Okay, so direct acting drugs means they are blocking the receptors directly. So how many receptors do we know? Alpha and beta. So we are going to study about the alpha blockers and the beta blockers. One beta blocker that we have already studied is propranolol. Okay, now we'll start with the alpha blockers. These are direct acting drugs. Now in alpha, how many receptors do we know? We have alpha 1 and alpha 2. If we block both the receptors, alpha 1 and alpha 2, we call it non-selective. If we block only alpha 1, we call it selective alpha 1 blockers. So easier way to remember is, since non-selective is blocking both alpha 1 and alpha 2, you can think that it is a strong vasodilator because it is blocking 2 receptors. Think of it this way. Yes, it is a strong vasodilator. So it can be used in emergencies. Okay, it can be used in emergencies, that is due to vasoconstriction. Means vasoconstriction will cause increase in blood pressure. So there is increase in blood pressure and emergencies related to this. Do you remember those 2 emergencies? What are they? One is cheese reaction. The other one is clonidine withdrawal hypertension. Now these 2 are emergencies or crisis that is happening. Cheese reaction and clonidine withdrawal hypertension. Here you can give non-selective alpha blocker. In non-selective alpha blocker you have to remember 2. One is phentolamine. Phentolamine is what is drug of choice in cheese reaction and clonidine withdrawal hypertension. The other one is phenoxybenzamine. This is used in pheochromocytoma. How to remember both of these? Easy. P for P. Yes, and see the length of this name, almost the similar length. So the big drug for the big condition, and phentolamine for cheese reaction and clonidine withdrawal hypertension. Okay, phenoxybenzamine for pheochromocytoma. This finishes the alpha blockers that are non-selective that are asked in the exam. Now coming to the selective alpha 1 blockers. Selective alpha 1 means it is blocking only alpha 1. Now unfortunately in alpha 1 again we have 3 receptors: alpha 1A, alpha 1B, alpha 1D. Now how did we remember the alpha receptor? If you can recall it, alpha 1 is the most important, so it is present on the most important sense, that is I. So it should be alpha 1A. So on the I and prostatic urethra we have alpha 1A. Now B and D receptors, these are present on blood vessels. B and D, these are present on blood vessels and they will cause vasoconstriction. And in prostatic urethra, exactly where is it present? It is present on internal ureteric sphincter and it will close this. This is what alpha receptor is doing. That is why I told you alpha receptors are a must know. You must remember these receptors even if you cannot remember the other ones. So how did I remember this? Alpha 1A eyes and in the prostatic urethra. B and D. You can see here BD. If you smoke BD, it will damage blood vessels. No? So that is how I remembered. Anywhere you see B and D, subtypes of B and D, they are mostly present on the blood vessels. If you understood this much. Again in selective alpha 1 blockers, we have 2 classes. One is blocking all these 3 receptors, 1A, 1B, 1D. The other one is blocking only 1A. Now what is important here? If 1A is blocked, 1A is present where? In the internal ureteric sphincter, it is closing it. So it will open the internal ureteric sphincter. So this can be used in a condition known as BPH. Why BPH means benign prostatic hyperplasia. Let us suppose this is urinary bladder and this is the urethra. Then there is prostate gland. If the prostate gland is increased in size, it will compress this urethra and the person is not able to urinate properly. This happens in old people. Now, if you give alpha 1A blocker, it will open this sphincter a little and it will relieve the symptoms. So it can be used in BPH for symptom relief. Please try to understand this. It will not decrease the size of the gland. It is only used for symptomatic relief. Now, B and D will cause vasoconstriction. If you block this, it will cause vasodilation. So it can decrease the BP. So it is drug of choice in patient with BPH with hypertension. Yes, what are the drugs? All these zosins, prazosin, terazosin, alfuzosin, doxazosin, any zosin, you know, all of these drugs are alpha 1A BD blockers. Now, there is one special side effect for this. Because it is decreasing the BP, it can cause postural hypotension. So, what if a person is having only BPH? Would you like to give this drug? No. Why? Because it is causing postural hypotension. No, you don't want to cause postural hypotension in a normal patient. So, in this people, we have made one more drug. This is super selective. It is only acting on the 1A. If it is acting only on 1A, it will only open IUS and it can be used in BPH. So it is drug of choice in BPH. How can you remember this? Silodosin, tamsulosin. This is prazosin, this is silodosin, tamsulosin. Did you understand this much? Yes. Now, we will see here alpha 1A, 1B and 1D blockers. Examples are prazosin, terazosin, doxazosin, alfuzosin. Now, this is used in BPH with hypertension. Okay. Prazosin is also the drug of choice in scorpion bite. So it can be used also in scorpion bite. Now the problem with this is, if you can see here, both of these drugs are blocking alpha 1A receptors. So both of them will have some common side effect. What is the special side effect of alpha 1A BD? It is postural hypertension. But because it is blocking alpha 1A, it will have some common side effects. These are very, very, very important. What are these? Alpha 1A is present in the eyes. So if you keep on blocking the alpha 1A, then if it is activated, if you are blocking it, if you are activating it, so what is happening? The iris becomes floppy. So it will cause floppy iris syndrome. Alpha 1A is also present in the prostatic urethra. Yes, if the prostatic urethra is opened, now during ejaculation, we need the movement of prostatic urethra, contraction and relaxation. Here, this is opened forever or it is opened for some period of time, so there will be no proper ejaculation. So, if the ejaculate is not coming forward, it will go backward. That is what is known as retrograde ejaculation. And then there is no ejaculate coming out. That is what is known as ejaculation failure. So you see all of these with both classes of drugs. Now, maximum side effects are seen with silodosin. Why? This is only blocking alpha 1A. So it will act mostly on alpha 1A. Yes, it is not acting on B and D. It is only acting on alpha 1A. So it is powerful blocker. So silodosin and tamsulosin will have maximum side effects. How to remember this? See, both of them are sexual side effects. So sexual side effects, S for S, maximum and silodosin. Very, very, very important topic. Most probably they'll ask you about the alpha blockers. If they're asking about the non-selective ones, it should be phentolamine or phenoxybenzamine. If they're asking about the selective ones, it can be prazosin or the other one is silodosin, tamsulosin. Did you understand? So next, going to the beta blockers. Beta blockers you'll study everywhere in the cardiovascular system. Okay, all of these are ending with lols, with the name lol in them. Any lol is beta blocker. First drug we have made, that is prototype drug, is propranolol. In this we have 3 generations of drugs. What are they? First generation means it is non-selective. Obviously it will block both beta 1 and beta 2. So if it is blocking beta 1, what will it do? It will decrease the heart rate. So it can be used in patients who are having increased heart rate and stuff. Yes, you will see it in cardiac heart failure, chronic heart failure. You will also use it in patients with hypertension. You will study all of this in CVS. Now, if it is blocking beta 2 is what is causing vasodilation. If you are blocking this, it will cause vasoconstriction. Is vasoconstriction good? No, obviously. Why? Vasoconstriction can increase the BP, and most probably the worst part is it can also cause erectile dysfunction. That is why we don't prefer first generation. So we have made second generation. What is second generation? It is cardioselective. That means beta 1 is present only on the heart. So we have made second generation, which is acting mostly on beta 1, some activity on beta 2. So that is why it is known as cardioselective. But there is still some activity on beta 2, so there is still minimal vasoconstriction. So what did we do? We tried to make a third generation of drugs. In this, there is an additional property to these drugs. What is the additional property? Vasodilation. Additional property is vasodilation. Okay. Now, it doesn't matter where these drugs are acting on, which receptor. It can be cardioselective or it can be non-selective. It does not matter. Okay. So, third generation drugs will have both cardioselective and non-selective drugs, but they have an additional property that is known as vasodilation. This is what I want you to understand, the subtle differences, the subtlety most of the people don't get. If you understood this much, now I've given the classes of beta blockers. First generation, these are non-selective. Then I've written cardioselective. Second generation is cardioselective, and third generation cardioselective also I've added here. So this is the second table. Third table is third generation and non-selective. So this is the table you have to go through about the laws. Yes. Now I told you some stories during the classes about the sotalol, nadolol and all of this. But we don't have that much of time, and this is also not needed for the exam. But what you can remember is nadolol is the longest acting beta blocker. Nada means, nada that you used to tie for the pants in Hindi. So these are usually long, so you can remember this is the longest acting. What about the shortest acting? Shortest acting is esmolol. Esmolol is the shortest acting according to the textbook. Now there is a new drug that has been approved, that is what is known as landiolol. Landiolol is even shorter acting than the esmolol. Yes, I am not going to give you a mnemonic for this because my students have made a very creative mnemonic. People who know Hindi will understand this, so I am not going to make it. Yes. So coming to the cardioselective drugs, how do you remember this? There is a mnemonic, that is new beta blockers. New beta blockers act exclusively at myocardium. That is the statement. No, cardioselective means it acts exclusively at the receptors of myocardium. That is what I told you. New beta blockers act exclusively at myocardium. New is nebivolol, beta is butoxolol, blocker is bisoprolol, act is acetylcholine, exclusively is esmolol, at is etinolol, myo is metoprolol, cardium is celiprolol. Now what is important? First two, nebivolol, butoxolol and the last drug, these are third generation, the rest all are second generation. Now what is the most important drug in all of this is carvedilol. Why is this so important? Carvedilol is a calcium channel blocker, alpha blocker, beta blocker, and it also reduces the oxidative stress. How can you remember this? C for calcium channel blocker, A for alpha blocker, R for reduces the oxidative stress. This is what I want you to remember for now. Okay, so these are about the beta blockers. Now in the beta blockers, about the propranolol. Propranolol is also drug of choice in infantile hemangioma, akathisia, migraine prophylaxis, portal hypertension, tremors and thyroid storm. So we will study this respectively in their chapters. Yes, for people who have attended the classes, I have made a big story on the beta blockers. If you know this, you will understand all the user side effects and contraindications of this. But for now, remember this much for the exam. Okay, good. So this is about the direct acting drugs. What about the indirect acting drugs? See, indirect acting drugs means they should block the synthesis of norepinephrine and dopamine. Now, there are many drugs like metyrosine and stuff, we don't use them, but the most important drug that we actually use is VMAT2 inhibitors. VMAT2 inhibitors. See, if the dopamine has to go into the vesicle, this has to be transported through VMAT. VMAT means vesicle monoamine transporter. If we block this, will dopamine go inside? No, it will not go inside. So dopamine levels will decrease, isn't it? What are the drugs? Reserpine. We don't use it anymore because it is causing depression. If the side effect is depression, the people will die, isn't it? So the next one is valbenazine, tetrabenazine, deutetrabenazine. So all these drugs are VMAT2 inhibitors. These are actually used. Yes, about these uses we'll study it in the CNS chapter while we are studying the schizophrenia. Okay, so these are the indirect acting drugs. We'll study it there. Now, alpha blockers, beta blockers. Alpha blockers are very important, especially the phentolamine, prazosin and silodosin. You have to know this. So this is about the sympatholytics. If you understood this much, then we'll try to solve the MCQs and we'll go into the next chapter. Okay, so you can see here a 60-year-old man with heart failure with reduced ejection fraction, that means HFrEF, is being treated with carvedilol. Okay. He also has type 2 diabetes mellitus, for which he is on oral hypoglycemic agents. Okay. After fasting for 2 days, he develops hypoglycemia. I told you, hypoglycemia is an emergency, no? So it will activate what? Sympathetic nervous system. So what will sympathetic nervous system do? It will release norepinephrine. It will act on beta receptors. Good. When it acts on beta receptors, what will happen? It will increase tremors, it will increase palpitation, it will increase glucose. Great. Now, but what is the question? Which of the following symptoms is most likely to point towards hypoglycemia in this patient? So, all these things will be seen whenever the patient is having hypoglycemia, and all of these are happening because of beta receptor. But here the patient is on carvedilol. This is what is very important. He is on carvedilol. Now carvedilol will block this beta receptor. It will block everything. Now when sympathetic nervous system is activated, if you remember the sweat gland, it has M3 receptor. On this acetylcholine will act. Did you understand? Can carvedilol block this? No, because it is not beta receptor. No. So you will still see sweating. That is the reason why you will still see sweating in a patients who are having hypoglycemic awareness with use of beta blockers. See, beta blockers are not generally given in diabetes mellitus. This is the reason. It masks all the symptoms of hypoglycemic awareness except for sweating. Good. Now, next one. A 55-year-old man suddenly collapsed while jogging, okay, is brought to the emergency department where he is found to be pulseless and unresponsive. So he's gone into asystole. You can say it cardiac arrest, okay. Cardiopulmonary resuscitation is started, CPR, and the decision is made to administer epinephrine, okay. Common sense, cardiac arrest, epinephrine. Which of the following is the correct formulation and route of epinephrine administration in this setting? If you already know the answer, try to remember it in the head itself, because seeing in the options you might get confused. Cardiac arrest you already know. You should give it in IV. And what is the dose? 1:, what is the dilution? 1:10,000. You can see here, where is it? 1:1000, no. 1:1000, no. 1:10,000, okay, but IM, no. It is 1:10,000 IV. This is the answer. What about 1:1000 IM? It is for anaphylactic shock. Anaphylactic shock. Yes. Coming to the 8th question. A 25-year-old male presents with recurrent episodes of shortness of breath and wheezing. Okay. He has been prescribed inhaled salbutamol for symptomatic relief. Maybe he is having asthma and he's been given salbutamol. Okay. Which of the following adverse effects is least likely to be associated with this medication? Okay. Now, what is the person having? He is using the beta-2 agonist. I have already told you, this is the question that has been asked so many times. Beta-2 agonist, they will cause tremors and then they will cause palpitations. So these are not the answers. Okay, and it will increase the glucose. Yes. Hyperglycemia, not the answer, but it will decrease the potassium. Hyperkalemia, this is the answer. This is not seen. Hypokalemia is seen. Did you understand? Now, going to the next question. A 45-year-old man with a history of depression has been on treatment with a MAB inhibitor. He is using MAB inhibitor. Okay. one evening after consuming wine and cheese. Wine and cheese will have what? Tyramine. It is norepinephrine displacer. He suddenly develops headache, palpitation, sweating and flushing. On examination, his blood pressure is 190 by 120 mmHg. He is rushed to the emergency department. Which of the following drugs is most appropriate for the immediate management of this patient? So, if you see here, a person is using MAO inhibitor and is getting tyramine. It could be from cheese or something. It will cause hypertensive crisis. This is what you must have studied. This is what is cheese reaction. So what is the drug of choice in cheese reaction? It is phentolamine. What about phenoxybenzamine? It is used in pheochromocytoma. Pheochromocytoma. That's all. Now, so that's all about the sympathetic nervous system.